So I'm Jennifer McGrath. I'm at Concordia University in Montreal, and I'm excited to chair this next session. We're structuring this a little bit different. I'm going to do a very quick introduction to a lot of the common methodology that has been occurring over the projects that we've been doing. It's sort of streamline the next set of presentations. That'll be followed by 3 different speakers that'll talk about each of them looking at a unique child health outcome, and then that'll be followed by a panel discussion. So let me first give you this nice overview of some of the methodology we've been using within the EPOCH cohort study. So the original mission of EPOCH was actually, the inception took place at Warwick when we were there at our second INRICH workshop. And this was this idea that we sort of sat around and had these conversations and kept thinking, like, well, what do we want to do? And the goal was to think about if there was a way to pool a lot of the data that we all had access to look at some of these questions that were pressing. So we have a bit of a convenient sample of 7 birth cohorts. And the criteria for being selected is that we wanted to ensure that we had representation across the Gini index, and that all the cohorts that we had access to the original data. It's not the case that we are capable of actually pooling the data. So we actually ran analyses at each individual site and then pooled those results, and I'll show you how we went about doing that. But the 7 birth cohorts we have representing internationally: Sweden, the Netherlands, Australia, the UK, Canada, Quebec, which is special, and USA. Quebec likes to think of itself as its own nation, so that's why it got to be in here. And just to give you a sense of the sampling characteristics, all of the cohorts are deemed to be population-based. They do vary in their level of representation. So they were approximately all within 1 decade of when the baseline was done. These were all birth cohorts. Nearly all of them started between birth, some before birth, to the first year of data. And there's some that we don't have data until up to the age of 5 years. And then we were looking at the child health outcomes at around age 10. And so we identified these cohorts because we had access to them, but also because they really overlapped and were as close as we could get in terms of their methodology to be able to look at comparisons across them. So the key work that we did was to think about how to do some harmonization. And this is actually based on the original work with Kate Pickett, and her student at the time was Philippa Bird. And so they really led and spearheaded the initiative to think about how to best harmonize both income and education. And so leaning on the work that they did, we looked at SES exposure within the first few years of life. Household income, we looked at both local currency, and we did a conversion, I'll explain it in a moment, to look at purchasing power parity. We equalized income whenever we could, if possible, weighted by household members. We looked and we made the decision to divide the data based on tertiles or quintiles, and I'll show you those categories in a moment. And for maternal education, we were using classifications again to create tertiles. So purchasing power parity, we were using this just basic rate of currency conversion to equalize that purchasing power. So this way we sort of eliminated any differences in the price levels between countries. And so that was identified as sort of the best, most optimal way to harmonize this data. And we were using it based on the OECD estimates for the year 2000, which was appropriate for these cohorts. So to give you a sense of where we were to look at the SES exposure at baseline across the 7 cohorts, you can see whether or not the income was based on the net or gross income, if it was able to be equivalized or not, and then what the quintiles were. And I'm going to just show you in a moment. You can see the last is the Gini coefficient. So just here, if I quickly plot them out, you have on your left axis the purchasing power parity, and then on the other the Gini coefficient to give you a sense, organized in order of Gini coefficient, of how much variability we had across them. And then for the maternal education, we were using the UNESCO standard of the ISCE, and this was grouping them into either low, middle, or high based on the years of maternal education. And so here was the baseline SES exposure across the different groups. There was actually very minimal missing data. And if we look at the graph of that, again, plotted against the Gini coefficient, you can see how they varied. So these metrics that I'm showing you these baseline exposures, are what will be common across the next 3 presentations that you see. So our guiding research question was thinking about, is SEA exposure during early childhood, that's that birth to approximately age 1 year, are they linked to health inequalities during late childhood, specifically around age 10, across these different country settings? And the 3 ones that we're going to focus on today were asthma, oral health, and obesity. We also tried our best to harmonize the baseline confounding variables, and they were intentionally selected to potentially reduce any kind of confounding bias that might exist. So the 4 that are common across all of the papers that we'll be talking about today were ethnicity, and to harmonize that, we were able to group them into either ethnic majority or minority. Some of the cohorts don't have that information, but instead they have whether or not there was an immigrant status or not, if they were born in country or not, and so we did our best to group those. We had maternal age at birth based on categories, child sex, and I should say that at the time none of these cohorts were thinking about or distinguishing sex from gender, and whether or not there were multiple births. And I'll make a note that we use these baseline confounders, but we actually did not adjust for potential mediators. And the concern is that we just wanted to make sure that we were avoiding any kind of bias that might be occurring on any kind of conditioning or any colliders. And that's something that we will look at in the future. But for the goal of these papers, it was really just looking at the baseline confounders. So our analytic approach took 2 paths. First, we looked at relative risk. And the relative risk was really to look at that relative inequality to look to see whether or not the disadvantaged groups and to what extent they were affected compared to their wealthier counterparts. The absolute risk is to look at the magnitude of the health outcome within the population, and this conveys the percentage of the population that's affected. So it's accounting for already the extent of folks that are identified as being lower SES. So I'll go into these more quickly. So the relative risk is what we use to look at this relative magnitude of difference. And we use this doing generalized linear models. We used log link and robust variance estimation. We have 2 types of ways we looked at the data, both using unadjusted risk ratios and adjusted. So the unadjusted were just the bivariate associations, where the adjusted controlled for the baseline confounders that I just presented. And to give you a snapshot to sort of get you used to what you'll see in the next few, you'll see these forest plots that were used to look at the relative risk visualization. So here's the first example with looking at ever asthma. So relative to the highest SES group, these are both just for now for income. The top group is for the middle category and the bottom to the lower category. You can see that the overall shows that their risk is higher compared to the highest SES group. For the absolute risk analysis, we calculated the slope index of inequality, and this represents the absolute difference in prevalence between the most and the least advantaged groups in the population. And so this is a linear regression-based index, and what's nice is it's accounting for that socioeconomic distribution of the population. So you're factoring out, you're partialing out the size of the SES groups. And so here's the visualizations that you'll sort of see. And so notice that the slope of the line reflects that slope index of inequality. The height of the line is the prevalence of asthma. So the flatter the line, the less inequality we have. And so you can see that, in fact, for this example, for ABIS in Sweden, right in the middle, has a very low, and the highest being up top with Australia, the LSAC group had the highest amount of inequality. So the EPOCH has looked at a number of different health outcomes. Again, today, the ones that we're going to focus on are obesity, oral health, and asthma. We have some others that are underway. And just to give you a little snapshot in terms of where we've been for the EPOCH group, we've done a number of steps in sort of thinking about how to prioritize the work that we're doing, it's a lot of effort between a lot of folks. These are the outcomes we've looked at so far, and the next steps are hoping to look for mediation and potential trajectory models down the road. And this is an enormous project with an enormous number of people that have been involved, most and many of the people that are here in this room. And the folks that I've highlighted here are really the key folks that meet every 3 weeks to continue working on this project. So what we're going to do as I transition to make the introductions, we'll take questions that are really technical based in between the presentations. And any substantive questions you have, I'm going to ask you to hold them for the panel discussion. Okay? So the first speaker will be Junwen, and Junwen is going to talk to us about asthma.
Thank you, Jennifer. Hi everyone, I'm Junwen. I'm a postdoc researcher in Erasmus Medical Center. So I'm happy to be here. Now I introduce the results we found in the asthma paper. Yeah, so as we all know, asthma is one of the most common chronic conditions in childhood. And apart from the diagnosis, we also know that wheezing as one of the most used in epidemiology studies is the most important symptoms that related to asthma. And we know that wide variations exist in the prevalence of childhood asthma worldwide. So from this figure, you can see that between 2000 and 2003, a survey among children aged 13 to 14 years old, the prevalence of ever asthma in Western Europe is around 16%, but in North America it's 22%, in Oceania there will be 32%. And we also find similar variation in wheezing symptoms worldwide. And for SES, as we all know, children's SES can be measured by, for example, household income, caregiver employment status, or the parental educational level. But the previous studies that capture the association between SES and asthma-like outcomes, it's always inconsistent. We consider the possible reason could be that the different definition of SES vary across the studies, and this difference make it difficult and challenging to compare between the health inequality. And also, we know that usually we measure the relative inequality, but the absolute inequality, as Jennifer has already introduced, it also gives a valuable insight from public health perspectives and take into account the overall prevalence of the disease. So in this paper, in addition to asthma and also wheezing asthma attacks as the symptom, we also take into account the use of medication because it can capture the current symptoms and severity of asthma. So the total aim of the study is that we study the association both in relative and in absolute terms in maternal education and household income at early childhood. And then the outcomes we are interested in is ever asthma, wheezing asthma attacks, and the asthma with medication control later when child is around at 9 to 12 years old. So based on this EPOCH collaboration, we have 7 cohorts from 6 countries. And in this study, in total, we include over 31,000 children for the final analysis. Yeah, and the SES variables we use is household income and maternal education, both in 3 categories. I will skip the detailed explanation. And the outcome. So first of all is the ever asthma. It is collected by the questionnaire. Parents indicate in the questionnaire whether their child had ever been diagnosed of asthma by a health professional. And also the wheezing asthma attacks, it is information regarding past 12 months, and the parents indicated that also in the questionnaire. It defined a little bit different in different cohorts. So in Netherlands and Australia, it was defined as attacks or illness of wheezing. In UK, Sweden, Canada cohort, it was written in the questionnaire as wheezing or whistling. And in the remaining cohorts, it's wheezing or an attack of asthma. So we consider that all in as wheezing and asthma attacks in this variable. And last but not least is the medication control for asthma. So it is a variable that we combine with asthma, and then whether the children has used asthma-related medication in the past 12 months. And in this case, these all 3 variables was measured at child age 10 to 11 years old. And the risk ratio was estimated in each cohort and combined later using the meta-analysis. And also we calculate the absolute risk, the SRI, to capture the percentage of population that is affected by asthma. So here are the results. First of all, we can see that the prevalence of ever experiencing asthma that range from 8% in the Netherlands and to 29% in Australia cohort. And then the prevalence of wheezing or asthma attacks that ranging from 3.9% in Quebec cohort to the highest 16% in the USA. And the final prevalence of medication control, it ranged from 4% in the Netherlands to the highest 11.8% in Quebec cohort. And here is the first plot. You can tell that we find that increased risk in children with lower SES condition, both in maternal education and household income, in the ever asthma prevalence. So both results are significant in the overall effect. And from the SRI figure, we can tell that the direction is confirmed. So with increased risk in lower SES group, and we find that the largest in the Australian cohort, but the lowest as in the middle, like the gray line with the Sweden cohort. That is according to the household income situation. And then if to the maternal education, we found the largest inequality still in Australian cohort, and the lowest in the USA cohort. And regarding wheezing and asthma attacks, we found a significant overall effect with increased risk of children from lower household income, but not in the children with a lower maternal educational level, even though the direction is still consistent. And with the absolute inequality, it's interesting to see that with UK and Sweden cohort, the direction is a little bit different from the remaining cohorts. So it's like increased risk in higher SES group, but the remaining cohorts showing that increased risk of children having wheezing symptoms in lower SES groups. And that is the case regarding to the maternal education. But if regarding to the household income, the direction is consistent. So confirm the results we got from the relative risk ratio. And last but not least, it's the asthma with medication control. We also only found the significant results in higher increased risky children from lower income households, but not significant results in children with lower maternal educational level. And with the SRI figure, we see that with the direction regarding to maternal education, it confirmed with the risk ratio, but but still, like the results from Sweden cohort are a little bit different. So the direction is increased risk, but with higher SES group. And in the results regarding the household income, we found a quite large absolute difference in Canada cohort. But then the remaining cohort, the number is slightly lower than the Canada cohort. So in general, we find pooled estimates for all three outcomes regarding the household income. So with increased risk of children having ever asthma, wheezing symptoms, or like say current asthma, like medication control, regarding to household income. But the estimates for children with maternal education level, we found significant results regarding to ever asthma, but the other two outcomes, so wheezing attacks or asthma with medication control, it is in the expected direction, but the confidence intervals cross unity. And regarding the absolute risk, except for wheezing by maternal education in the UK cohort or by income in the Swedish cohort, the remaining absolute risk by income and maternal education was in the expected direction, so it complements the findings of a relative risk. And the prevalence rate in the current study of ever asthma ranging from 8 to 29%. It is generally lower than the latest international study of asthma, the phase 3 of ESAC, that is collected in 2000 and 2003. A possible reason could be that because the data collected in current study is later than this time period. Only the USA cohort has some overlapping years. And then the recent study shows that asthma prevalence has plateaued or even decreased in recent years. So maybe it can be an explanation that why the prevalence in the current study is generally lower. But we still find a pattern that the asthma prevalence is particularly high in English-speaking countries, Western Europe, and now some of the more affluent Asian countries. And as for absolute inequality, we can explain that like, for example, the largest potential reduction in asthma prevalence according to higher maternal educational level would be observed in Australia and Netherlands, which means that taking into consideration the prevalence of the affected disease, one increase in the maternal education level would lead to the most in Australia and Netherlands, the drop in these two countries. And the similar explanation to the household income would be that the largest reduction can be seen in Australia with the reduction in asthma like 9%, but as well as Quebec, Netherlands, and UK, so the similar reduction will be around 7%. And as we already see that we also didn't find the consistent significant results in the maternal education with asthma and with the rest two outcomes. Traditional relation between lower SAS with asthma-related outcomes is evident until children are aged 9 years, which means that among children older or in adolescents, mixed results are reported. We also only confirm within more related to the income. We can think of that as one explanation as when children grow older, a large portion of their day will be spent in school and neighborhood. So the family SES, the influence mostly about housing conditions can be a little bit less, the children less to be exposed to that. So that's why maybe the association is not that consistent with other studies. And in addition to asthma, to the symptoms, I think most also importantly is to improve the asthma control. So in this case, the first thing is to avoid triggers. That includes at home, in school, like the damp, like the situation, and also the air quality, like the secondhand smoking, this kind of trigger. And second is to increase the knowledge for both parents and school teachers. This involves school nurses or specialized asthma nurses to increase this knowledge to better help the parents and teachers to help the kids to better follow up the treatment plan. And also, of course, the parents have those trust in the doctor and their optimism about the possible effect of the treatment, because sometimes we know that parents may consider it as it's a lifelong disease. It cannot be treated. So the optimism in following the plan will be less, probably in lower SES groups. So that's what I think will be important, that what we can do to better improve the asthma control. So that's all for this study. Thank you.
Okay, so our next presentation in the EPOCH group is Par, who will be presenting today on his work with obesity.
Hello. My name is Andersson-White. I'm a pediatrician and working as a clinician with children with diabetes and obesity. And I've also been the lead author of this paper on obesity from the EPOCH group, the corresponding author. So I would present the results today. So as all of you are probably aware, the prevalence of obesity in the world, especially in high-income countries, is increasing. There were some evidence that increase plateaued at the beginning of this millennium, but there's still now, in the recent years, evidence of some slow increase. And also important for this topic is that most cross-sectional studies show increasing social inequalities in obesity. So the rationale for this study, which was part of the EPOCH project, was to try to compare the gradients of inequality across countries. And that is difficult when you look at separate studies, because often there can be methodological differences that affects the results. So as Jennifer explained, we have harmonized the variables as much as we could to eliminate these factors. And the aim of the study was to describe the longitudinal relationship, both in relative and absolute terms, between childhood SES and the development of obesity in late childhood, age 8 to 11 years. The definition of obesity, there are currently 3, I think, that is most commonly used, but we use the IOTF definition, the International Obesity Task Force. And that give a little bit lower prevalence, for example, compared to the WHO or CDC definition. The SES measures were similar to the other studies, so they have already been presented. So this is a table of the prevalence in the different cohorts. So as you can see, there is large differences. Sweden had the lowest prevalence at this time point, 2.6%, followed by Holland, 3.1%, and then we had a group of countries, Canada, Australia, and UK, with about 6 to 7%, and then the US was in a league of its own with 16%. When we look at inequality, we see that we use income as the SES measure. We have an increased risk of, a pooled risk of 1.73. So there is an increased risk of overweight if you have a low income across the cohorts. But we also see a significant heterogeneity. So, for example, if we look at Sweden, the relative risk was only 1.16. And the highest risk in low-income families was in Holland, where it was 2.83, so significant heterogeneity between the countries. For obesity, we see that relative risks are higher, and this is something that is often reported, that the relative risks of obesity is higher than for overweight. The pooled risk was 2.83, which is also in line with some previous studies. And again, heterogeneity with almost no risk increase in low-income children in Sweden and a very high increase in the Netherlands in relative terms. For maternal education, the pooled risk was almost the same as for income, so it was 1.73 for income and 1.62 for maternal education. And again, some heterogeneity. For obesity, the pooled risk was, this was the SES factor with the highest increase, threefold increase in the pooled estimate. And here you can see that interesting finding that in relative terms, the US actually had the lowest increase in low maternal education, and I'll come back to that when we discuss prevalence and inequality. So another way of looking at inequality is absolute risks, and we have all seen examples of that. And this is the slope index of inequality of overweight, and we see when we calculate this that the flattest line is the Swedish cohort, ABIS cohort, and actually again it's the same picture in the relative risks. Holland Generation R had the highest inequality. For obesity, things become a little bit different. The US now had the highest inequality, and that is of course because of the high prevalence, which is reflected here. So there is a risk difference of 14% of obesity in maternal education and 18% in income if you have low income compared to high income in the US. And Sweden had the lowest absolute inequality, and the other countries are, you can see them in between here. So in the discussion of this paper, we start with confirming that there is a social gradient in obesity across the cohorts, especially if you look at in absolute measures. However, the slope of the gradient varies between countries, and we think that heterogeneity is very interesting to discuss, and what could be the explanation. So one thing that we talk about here is the relationship between prevalence and relative and absolute risk. So Johan Mackenbach and Hua Leng have a paper where they have looked at a number of health outcomes and confirmed that relative inequality tend to decrease with increasing prevalence, but absolute inequality follows an inverse U-shape. So this is what we see when we look at the US data, where we have a high prevalence, a high absolute inequality, but low relative inequality. But even so, this explanation doesn't fully explain all of our findings, because we have two countries with low prevalence, Sweden and Holland. And in Sweden we have a low absolute inequality, and in Holland we have a high absolute inequality. So these general patterns and the relationship between prevalence and inequality do not fully explain the findings. So we go on and we discuss some of the policies that we think could be important for these differences. And there are social and economical policies that I think we will get back to in the panel discussion. Briefly, the four major ones we discussed that have some evidence of decreasing inequality in obesity are universal meals in schools and universal preschools, ban on advertisement to children, and differences in parental leave regulations. So with that, I end my part of this presentation, and thanks to Jennifer and Johnny, my supervisor, who started the OBIS cohort, which is part of my data.
Thanks very much, Par. So we'll take just a quick technical question. Anders?
I guess a key methodological question in the EPOCH project is to what extent the representativity of the different cohorts of the population in the countries, and to what extent the differences between countries actually represent population differences or differences in representativity. And I don't know, Per, if you have compared your results with other studies of obesity in Swedish children.
Yes.
Because I don't recognize this lack of social inequality when it comes to obesity from the other population-based studies with a higher participation rate or those that we have from the child welfare clinics.
Yeah. So the prevalence in the obese cohort is similar to studies from Sweden in the same time period. So 2.6% was also what they found in COSI study, for example. The inequality level, you saw that the relative inequality in maternal education was quite high. It was, I think it's 2.8 or something like that in Sweden. So the maternal education in relative terms the inequality is high. But the finding with that low income is not related to higher risk of obesity. I think that is in line with other findings I've seen, for example, in diabetes, that low income in Sweden at the time when the children are small is not related to, for example, mean HbA1c levels, while maternal education is very important. So I think we can discuss this more later, perhaps. But often when they do studies in Sweden, they combine a number of SES measures, and then they will find differences, of course, because one of them will be educational level. So that's I think is the part of it, the differences. Yeah.
Thanks very much, Par. So our third and final presentation to do the introduction before the panel will be Sharon talking about oral health.
So I wanted to start with this because in our country we always do an acknowledgement of country, and so the work that this was done on was the land of the Wurundjeri people of the Kulin Nation, and I feel that there's probably people in the room that come from traditional owners in their own land, so I just want to acknowledge country wherever we are and wherever other people come from. So I've got the pleasure of talking about oral health or dental caries, and whereas to me, it kind of feels like one of those maybe less complex conditions that we could or should be doing something about. A highly prevalent condition, highly preventable condition, lots of children affected, and I'll tell you about the numbers that we've got in our study as well, but essentially anywhere between 60 to 90% of school-age children have some level of dental caries across the world. Of course, we see the majority of that global burden of disease in low and middle income countries, but clearly plenty in high income countries as well. And this picture here is kind of cool. This is what we often see in young children. They call it early childhood caries, which you see the caries at the front teeth. The second is that this is being taken up by the WHO and being adopted, this whole kind of oral health strategy. So there's this kind of increasing movement of us doing something about children's oral health. So it seems timely, at least, that we're looking at this across a range of high-income countries. The other is that there is, because it is highly preventable, the question are what are these kind of risk factors that we might be able to do something about? And these are the sort of risk factors that are associated with higher risks of dental caries, so things like access to dental care, dental hygiene, living in adversity, and unhealthy lifestyles. So these are the sorts of things that are associated with it. But I want to come to my next slide, which are the things we can do to actually prevent dental caries. And I'll get you to keep this in the back of your mind as I go through some of the results from this study and some of our thinking about the things that we could probably do very quickly to turn around rates of dental caries. So one of them, obviously, is about access to dental care. The other is exposure to sugary drinks, and obviously this overlaps with the obesity presentation you just heard about. And the third is water fluoridation. And as I said, keep this in the back of your mind. I'm actually going to present two studies, but I still will do it quickly, don't worry. One of which is the Australian work we did looking at oral health, and then the segue into the EPOCH work. Before I do that, I just want to acknowledge my three Australian colleagues who've worked on this, and in particular Fiona Mensah, who was actually on the calls late at night with everybody. She's a statistician. She's the one that's actually really been guiding a lot of the statistical work, and so I just want to really make sure we acknowledge them. So the first study was this one, which was done from the longitudinal study of Australia's children, and I'm not going to spend a lot of time on it, but I do want to bring it up because we were able to look at these kind of policy modifiable oral health factors that you can see listed there. And the reason I'm going to show it to you is because of the results, which I think you're going to find quite interesting. We couldn't do all of this in EPOCH because of our ability to not be able to compare adequately. So the kind of results from this were really interesting. So first of all, this won't shock you because it's exactly the same for absolutely every single one of the studies that we've got, which is this social gradient for, and as you can see there, between the highest and lowest. So essentially you can see age down the bottom there. Dental caries gets worse, so starts off lower and gets higher as children move into the school age group. And there are differences between the highest and lowest income quintile. And I can tell you this is the same for each of the EPOCH studies as well, even we don't have it over time. We only have one age group, unfortunately, but the social gradient exists everywhere. The second thing is this, the one on the right, and I just want to highlight a couple of things to you because we were able to look at services. So this is looking at, in the 2 years before 8, well, I think this is 10 actually, whether they had caries and whether or not they used a service and whether they used that service for prevention. And what you can see in the bits that I've circled is the difference between the preventive use of services between the low income, which is down the bottom, and the high income, which is up the top. So there's quite a stark difference between high and low income use of preventive services. And then, of course, the opposite, which is use of curative services when you actually have caries between the bottom, again, looking at the high income, which is 6.5%, and the low income, 2.6%. So the reverse of what we're seeing. So we're seeing high use of preventive services in high income families and lower use of curative services in low income families. And this kind of pattern, I think, is really important because it goes to all of the countries we've included the way that services get used. So that's kind of like just hanging that out there. The other is water fluoridation. So fortunately in Australia, we could actually look at the level of water fluoridation in each of the areas that children lived in the longitudinal study of Australia's children. We can't do that for EPOCH. And I wanted to put it here because I didn't want us to lose the fluoride story in all of this, because it's a really powerful story, and most of the EPOCH countries don't have artificially fluoridated water in their countries. So this is looking at the relationship, again, between water fluoridation and socioeconomic status over quintiles. And what you can see in the bottom is these are the fluoridated areas across quintiles, and the unfluoridated is the top line. And I'm hoping what you can see there quite clearly is that water fluoridation ameliorates the social gradient. And I think this is a really important story that we won't get from EPOCH because we don't have the levels of water fluoridation where the children live. So you'll see we've made some, assumptions about some things because there are naturally occurring water fluoridation, particularly in areas of Sweden, but we have really no idea about Canada, to be 100% honest, or the UK. So I wanted to include that as part of the story. So these are the Australian, I won't spend time on this because we haven't got time, but exactly what I've just said to you. And then, of course, there is the EPOCH study, and I just want to start with a couple of things. First of all, you can see all of the authors there. I've got another slide with all the authors, but I won't put it there. But I particularly want to just acknowledge the people in the room who are authors. So Junwen is an author and did an enormous amount of work on Gen R. Jennifer is a co-author, and just her guidance around all the statistics was absolutely amazing. Who else is a co-author that's here? Par? No, Par's not a co-author. You! Liz is a co-author as well. I knew there was one other person. And then all the other people who are not here today. So just an amazing kind of group effort, and a lot of people, like everyone has spoken about, have done a lot of work on the actual studies themselves. This is just to give you a sense. We've gone through all of the other measures that we used across SES, etc., so I won't repeat all of that. But just to give you some of the challenges that we had about measuring tooth decay, which is essentially decayed, missing, filled teeth. But it is parent report on children's decayed, missing or filled teeth for every single one of the studies, except for Gen R, which is actual direct observation. And so in the paper we've published, we've talked about some of the challenges of those comparisons, but that's one of the challenges we have. The other challenge that we had, and just for noting, is in the Swedish study, the children's age is quite a bit younger, so they're 5 compared to the older children, and of course the overall rates of care is a bit less in those studies. But we were able to look at some of these other factors that were kind of interesting. The other thing is, and I know we're going to talk about this a bit more in the panel, so this is me. If Fiona was presenting this, she'd present all the statistics, and I'm presenting to you all the policy and service differences, so this gives you the sense of the different angle I'm coming from here. These are the differences in the way that dental services are funded and the access to services and the access to fluoridated water in each of the countries that we looked at. And I'm not going to read all of this out because I think you can probably see that well enough, although it is a bit small. But this became I think this is really important in helping us understand what we're seeing as part of these differences. And a really important part of this study, and in publishing this study, is trying to get some lessons from this in terms of our policy learnings. And that was really the whole point of EPOCH. It wasn't just, let's look at these differences, isn't this nice? It's actually, let's look at these differences and what are the learnings that we might be able to apply from each of our countries. So what you can see there's really, and I'll talk about this a little bit later, really important differences, particularly in the way that dental services are provided, and as I said, fluoridation of the water supply. Just to give you a sense of prevalence, and I didn't put this slide in, but just to give you a sense of it, so we're not talking about a low prevalence condition. In Australia, the rates of the prevalent rate was 41%. In Canada, it was 55.3%. In Gen R, it was 25.1%. And then in Sweden, it was 12%, remembering that they were the younger children. So we're talking about a really high prevalence condition. But I want to actually go straight to the slope, if you like, because I think this is where the story really is. And as we said, I think this was a really powerful statistical methodology that we could apply to all of the studies where you really understand these gradients. So I just want to go through each of them. I'm just going to talk particularly about the left-hand one, which is related to income. And so basically what the slope tells us is what would happen if we made everybody kind of wealthy, essentially. And so, and I'll talk about Sweden in a moment, but so pretty flat in Sweden, 16% lower for Australia, 34% would be lower for Rotterdam, and 36% lower for Quebec. So I think pretty quickly you can see where the greatest inequalities lie. And not dissimilar, but not quite the same results for maternal education. So, I think the gem of these papers are actually these slopes and the ease of understanding them. So this is kind of really the conclusion for this, and that is when we had a look at Sweden, and we can have a chat about this in the conversation, there seemed to be a really unique combination of things happening in Sweden. They had this kind of really low gradient. Now you can say, well, is it because of the social gradient? But actually it's because of three other things. Number one, and we had a lot of chats to people, their universal provision of dental care is mainly in a huge kind of social contract around prevention. So you've got Amsterdam and Rotterdam, where you actually have pretty free-ish dental care, but not this kind of social contract around prevention, whereas in Sweden they have this very strong social contract around prevention. They've got more naturally provided water fluoridation than other countries, and then generally this kind of low consumption of sugar, and this, as I said, was particularly evident there. The other thing, and I'm going to talk more detail in the policy implications, I think, going forward, but we're doing these research snapshots. I don't know if other of you in the obesity and asthma people want to do, but I thought this might make a nice series. We tend to do these 2-page to 3-page research snapshots that we put out, and then we can kind of publish because it is other quite dense. So I'm going to stop there and happy to answer any questions.
Thanks very much, Sharon. So I'm going to ask if the panel members can make their way to the stage, and does anybody have any quick technical questions for Sharon before we get started? So Sharon, I'm wondering if you can just launch the conversation to just give maybe a brief synopsis of that, some of the work that you've done looking at sort of the policy experimentation, and then we'll sort of discuss that and how that relates to some of the different child health outcomes that we're looking at.
So we did a paper a couple of years ago around this idea of precision policy, and we sort of started borrowing from precision public health and precision medicine about this idea of what are the sorts of policies what you might need for which populations and when in order to get the greatest impact on equity or inequity, and in particular thinking about what are the kind of combinations of policies and what are the data sources that we might need that would help us think about what we might be able to do in certain spaces. And recognising that actually policy making is just an incredibly blunt process in general. You know, policy, I call it kind of policy vomit, but you kind of get these policies with a problem, you know, we see at the moment in mental health problems, and then you just kind of get this tsunami of policies that come out, generally not targeting the right people necessarily, generally not distributed across populations that might need it most, generally not evaluated. So you get this kind of mismatch between policy endeavours and then impact. So sort of had this paper that sort of was a call to action, I guess, to researchers to say, what are the data that we might need that would give us some precision for policy that would tell us which policies ought to be targeted, where, when, etc. And it goes to our kind of frustration, I think, across this whole group of the dissonance between the evidence that we're gathering and the inability to impact effective policy in that area. And we just know that that kind of knowledge to action gap keeps killing us. So it was this kind of call to action to say, part of it is this kind of dissonance between knowledge to action, and part of it is, do we need to be framing our research findings and our data analyses around precision policy? What do policymakers need to actually implement policies that are going to make a difference for child health and developmental inequities?
I just wanted to indicate that, in fact, that is true, that one of the important things, and I've shared these findings with people in Quebec, and the demonstration that it doesn't have to always be unequal, and that it folds out differently in different countries for different outcomes is actually important, because it does demonstrate that you can do something. That's one issue. The other issue is, I think that having these data is that when it comes to developing policies, it's not just about the policies, it's about what level can the policy be implemented at. And, we have some cohorts that are national cohorts, other ones that are more regional or local, and the question of representativity is important, but many of the policymakers have indicated to us that what they really would like to have is data that's relevant for the constituency that they actually serve. And so that is also useful. But there's also the idea of the window of opportunity for developing policies. Sometimes there's an open window where people are saying, well, we're thinking about this and we'd like to do something. And it's important to have those data to say, we're ready to share it. Here's what we found. We don't have all the answers, but here is some information that may be relevant. Junwen, Par, Nick, did you want to add something?
No, not at present.
No, I'll add something, because I think we all, the results, the evidence now we show, it's also add to policymakers at some point that the comparison. So when we see the inequality, sometimes, for example, in one cohort, in one data set, it's showing, it feels, for the policymaker, it feels like, it's not the urgent issue, but when the comparison shows, like we put as the relative and the absolute inequality together, and then sometimes it's like striking, then hopefully it can be a more strong evidence to show. Yeah.
Okay, Anik, I'll start adding questions from the audience, and I really favor provocative questions. That's on you, Sue.
Oh man, I don't think I can be provocative. Tough. But I was really interested in the concept of social contract that you talked about, Sharon, and how that whole point of how do we make this data change into action, similar to what the CDC talked about today, which was really impressive. Like, what is that next step? What are we going to do? Because we don't want to admire the problem. There you go. I've been provocative. So I was wondering if the panel can expand on that.
Yeah, thanks very much, Susan. Yeah, I have a little bit of, I want to defend continuing to demonstrate how the social determinants of health determine health. We are still in a situation certainly in the UK, and I suspect in most of the countries represented here, where that approach to understanding health is still disputed, if not disputed, then ignored. I think if we cast our mind back to yesterday to David's presentation, this vast amount of evidence which clearly shows the effects of policy, specific policies. I don't know whether any of that ever appears in the mainstream media. And neither does it necessarily appear as much as it should in the pediatric world or in the medical world. And I still think there is a need for that. I entirely accept the need to have an approach to policy, but that needs to be policy both at a micro level, but also at a macroeconomic level. And I think that one of the things that all this work from EPOCH demonstrates is that high-income, high-education children are protected against all sorts of outcomes. Some of the most common outcomes that affect children and affect us as service providers. So I think it's important to continue to do that. I don't know whether... I see that Kate has her hand up. Does anybody want to?
I was just going to follow up just to say that I think this... I think that's where this kind of use of preventive services, for example, is a really good example of where both the social determinants and... so I think this is the kind of where there's kind of really kind of what I would call maybe these are where the kind of social determinants and health policy collide in useful ways, because if we can work out the right ways of delivering healthcare policy around things that actually prevent these common conditions, it doesn't come away from some people just need more money, but I do think there are these useful ways where health policy and social policy can collide, where we can actually start ameliorating social gradients. So I think that's both. But it depends which one we can get to first, because, you can't wait forever.
Thanks. I just want to back your point, Nick, about the need to keep on showing. And I think often as sort of health professionals, we sort of think, well, we know this, right? We've shown it before. Why do we have to keep on showing the same things to the politicians who egregiously ignore us? And they do egregiously ignore us. But journalists have forgotten or never knew. I mean, I'm constantly surprised by how when you speak to a journalist about a shocking statistic around child health inequalities, they don't know. They've either forgotten or they never knew, and there's a lot of churn. And so we do need to keep informing those who share our research more widely, because they don't know it in the same way we do. So the politicians might be ignoring us on purpose, and I think the journalists often aren't ignoring us on purpose. They didn't know. We have to come up with new things, because they can't do stories unless we feed them new things. And even if they don't seem new to us, they will often seem new to them. But also I think we need many more of what you were showing, Sharon. What did you call your briefing? We tend to call them research briefings. You called it?
Research snapshots.
Snapshots. Those sorts of things are so important, and we're doing a bit of research at the moment on what snapshots are most effective for policymakers in local authorities, nationally and whatever. Would they rather have a little briefing like that? Would they rather have a little video? Or about, what speaks to them the most? Because we don't always collectively, and I'm not speaking for anybody in this room because you're all brilliant at it, but as a public health sort of professional, we don't always communicate most effectively to those who need to hear us most importantly and sort of now. So we do need to keep showing it, but we need to show it in ways that people will read.
Can I just quickly say... that policy making is part of the social determinants of health. You can't escape, and that there are policy makers who have policies which are specifically favouring a particular section of society, and we have that in spades in the UK. But I suspect that's true of a number of other countries as well. So I entirely agree with the need to focus both at the micro and the macro level, but I think we need to recognise that policy is actually part of the issue of social determinants.
Thanks very much, David Taylor Robinson from Liverpool. I guess I think it's great to see the gradients across those cohorts. Then I think the next step is to try and understand the distribution of the mediators of those inequalities in order to understand some of the differences between countries. So we've done some comparison of mental health across some of the cohorts. And if you look at, for example, at the patterning of parental mental health problems, it's the fact that there's hardly any social gradient in mental health problems in parents in Denmark that explains differences in inequalities in child mental health. So just seeing the gradients in some of the mediators of inequalities in asthma or oral health, etc., and how they vary across the countries, I guess, is a really helpful next step. And then just really to Sharon on the precision agenda, do we think invoking precision approaches in public health is a useful step forward for us as a community?
Shall I answer that one? And also to your previous one, I really agree, and that's why it was useful to have the Australian paper where we could actually look at some of the distribution of some of the hypothesised anyway mediators. So I think, and I think we had a discussion about this at the time when we put the paper out. I think it's important for us in public health to engage with the public. So this is, I think, having an engagement with the public that doesn't isolate us out into this kind of, well, we don't really have anything in common with our colleagues who are doing clinical medicine, etc. So I think it depends what you mean by precision. I do think that there is a role for precision public health and precision policy, but that's not about necessarily everything has to be targeted and nothing's universal. But I do think it lends itself to a certain amount of accuracy, and I think it does. I'm hoping, David, these are not, lay down misère kind of ideas. I do think it provokes policymakers into thinking. I'm hoping it would provoke policymakers into thinking more deeply about the precision of their policies and where they might target their action. And at the moment, as I said, I think it's really blunt. I think it doesn't actually address the social determinants in the way that it could. And so I think it is useful in the current zeitgeist. But, I get the argument that says, does that take us down a targeted pathway and away from public health? I guess we don't know the answer to that.
Can I just add one point to that? Yeah, okay. I'll let you use mine. I thank you for that comment. I think that the idea of providing or precision policy is interesting, but if we're going to move forward in this direction, we will have to get data that does a really good job about talking about the heterogeneity across time and across space or different units. Because I think I mentioned that before, that we have national policies, regional, provincial, local policies, but we do have to continue to be able to monitor what's going on and to document the heterogeneity in population distributions, because that's where the precision policy or the precision issues might best be addressed. And we do have to address this issue that you mentioned, Sharon, is we have to start evaluating the impact of implementing policies using all kinds of quasi-experimental designs.
I'm noting a handful of hands up, and I have a little mental order for questions.
Alina Valderrama, I am a public health practitioner and researcher at Montreal. I think that the next step also is to offer innovations which could be efficacious for change this data, to offer new strategies to policymakers in a populational approach. Yesterday, for example, I loved the project about text messaging. Could we use it in asthma, for example? So it's unbelievable, but for so many these disparities, we don't have enough data with efficacious strategies for change these inequalities.
So the great thing to me about EPOCH is it's in the long line of epidemiological analysis that says, let's compare places. And it shows you what's possible. And, you know, we've been doing that for a long time in health inequalities research. So it's great that that's another example, because like Sharon showed, where here's what you could do, here's what's possible. That's really provocative. But I want to take up Lisa's point that you mentioned something about when you talk to policymakers, they go, oh, that's great for Sweden, but that's not where I work. So I spend most of my time talking to policymakers. And one of the things that I've come to learn is the world of politics is not the same as the world of policy, and that's not the same as the world of practice. So we need to get a little more sophisticated about what levels we're trying to influence. But if I can just talk about policy, I'll have a policymaker say to me, I want to do something for these disadvantaged kids in the north. Everybody knows where they live. I want to do something. What do we do? And if I give them a relative risk, their eyes glaze over and it doesn't motivate anything. So Lisa's point, we've shifted our whole epidemiological enterprise into using their own data. That means breaking down the barriers to the data the government itself uses. And we've written hundreds of reports, none of which make academic publications. But when the policymaker wants to know how many disadvantaged kids have we got at age 5 who are vulnerable in the north, I can say, you got 1,500. When we get absolute numbers at the local level, they then think, what's the size of the task to shift those kids? And that's where the stuff that Sharon showed with, well, if we shifted this many to this level, then that would change the overall population profile by this and reduce inequality by that. And it's that absolute number that gets them thinking about what's the size of the service slots that we need, what's the configuration of supports that we need. So I think we need what we do as researchers and to generate our relative risks. And as Jeffrey Rose said, relative risks are for researchers. Policymakers are interested in absolutes, but we have to crack that barrier into that data that they use themselves for their own resource allocation. And I think there's a huge role that epidemiologists and people like us can play, because they don't know how to use their own data that well. So I think we've got to walk both sides of the street, and I've been struck by the difficulty, Martin, the paediatrician, saying he can't link to the child services data from the paediatric stuff because it's against the law. So there's a lot of work to be done, but I would just, if we're really serious about doing policy and not just generating relative risks in academic papers where we basically talk to ourselves, then we're going to have to make that to get towards what Sharon's been advocating. That gets us closer to precision, I think.
Thanks, Sean.
Can I just pick up on that? Is that working? Yeah. I think what you're saying, John, is really important. I think one of the things that I would say in relation to that is that for research purposes, administrative data, what you have done, if I understood from our discussion last night, is to manage to link data in a way that the policymakers themselves hadn't done. What's been demonstrated over many years, for example, particularly in the Nordic countries, with the linking with through the medical birth information, and that then follows, and you can follow huge cohorts of children. Anders has been involved in that kind of work for a long time, but that, in a sense, is the absolute data, because you are dealing with the whole population and you can make conclusions from that. Now, how you analyze it and how you present that is something that obviously you have, what you've confronted is that the policymakers don't want what we want necessarily, but they wanted it presented in particular ways. But I think the argument I'm making is that administrative data is really valuable if you can start to link it to other administrative data.
I'd just like to add on to that question. Thank you for those perspectives, John. About the data, I think using the data that is relevant at a local level, I think is really critical. But another issue which I found to be interesting and challenging, and this is something that occurs in politics and policy and in practice and in research, is how you ask the question and what you're asking specifically in terms of the question. And when I read a master's thesis or a doctoral dissertation, the first thing I do is I look at the statement of the goals in the abstract, in the introduction, in the papers, and in the discussion. And if they're not aligned, I know that there's slippage and there's an issue there. I think that one of the things that we could gain a lot of insights from is asking policymakers and elected officials, what is it that they need to know, and what kind of information that they, how it should be delivered. And I think there was some discussion about that later. But I've always been enlightened by those kinds of conversations. Say, oh, geez, I didn't realize that that was an issue for you folks.
Yeah, I thought that was very interesting, thinking about these policies that we have discussed about obesity, for example, how they started. They were in Sweden with school meals, for example, in the 50s. I guess they knew that there were malnutrition. There was malnutrition they were trying to address. So they knew there was malnutrition, and they thought the easiest way to improve that was to provide free school meals. And I think to give a very clear message like that, of course now we have the opposite problem. We have obesity, and the families, the home environment is increasingly obesogenic with unhealthy food. And it's very common sense to say that providing healthy meals in schools, and preferably also breakfasts like they do in preschool in Sweden, makes sense. So, yeah, simplify the message maybe and relate it to the inequalities that we see. It's fine.
I'm keenly aware of the time. I have 2 more questions on deck, and then we'll conclude this session.
Well, it's not really a question. It's more of a comment. I mean, I think I said it yesterday already, but I'm really more increasingly puzzled about how to get the messages of our research out in a context where it seems like, at least here, our politicians are mainly concerned about decreasing taxes, decreasing costs, decreasing public spending. Of course, they say it's the EU and not them, but it's even getting complicated to talk about universal access to healthcare, which is supposed to be by law, actually. So one of the things that I try to do with the data that we have is also just sort of reassess whether some of the policies that are meant to be universal and accessible to everyone actually actually are accessed by people. And we've done that in the ELF study, looking at prenatal care, for instance, but also prenatal counseling for families, which is meant to be universal. And you realize that when you ask people about that, actually about 30% say that yes, they have gone to some preparatory session before their child was born. And of course, the families that go are the ones that are where it's their first child, they're more educated, they have probably better access to healthcare anyway. And it's not it's a very basic, very descriptive analysis, but I've actually been more and more using these types of, trying to frame these types of questions around, okay, well, we have a policy, that's great, but who's actually getting access and who's really benefiting from it? And maybe, I don't know, I'm just hoping that maybe that's something that some policymakers could be interested in. but there isn't actually really thorough follow-up. We have a big national policy now about the first 1,000 days after the child is born. Tons of communication and tons of... then there's a new website about telling people what to do. There's a new description of what childcare services should look like. And I'll be really curious to see what actually really happens and whether people actually use these different services. And hopefully that will be of interest to some policymakers. But it's complicated.
Can I just say one thing, because I know we have to finish up. There's a book by Kingdon, and I can't remember the name of it, but in it, and he's a US author, but in it he talks about these 3 things that you need for action. 1, that you need a policy window and sort of a level of political will. 2, you need great data, so you need to be able to describe the problem. And the 3rd is that you need an evidence-based policy solution. So coming with data without a solution also won't get you anywhere. And so I think that's always really good to keep in the back of our minds, because and the first bit of that policy window is so important, because, you know, often you're just beating your head against a brick wall. But when the policy window opens, like your first 1,000 days, and we've got an early years policy window, we're just kind of shoving anything we can through it. But I also want to say that, and just reflect, because I think there's some kind of junior faculty in the room as well, that there is a dissonance between the way we are funded as researchers and what it actually takes to translate research into policy. And I'm increasingly frustrated by that for our more junior faculty, because the rewards are actually for grants and publications, but the effort, which is often 2 to 3 times the effort of the initial grant or publication, is actually getting it into action. And John, who's a seasoned researcher, is actually spending, I bet, more time trying to work out how to do this translation stuff, building relationships, doing reports that don't get published. You know, that's actually how you get into action. So, I think, this is me having a bit of a kind of whinge, really, but it's just, this increasing dissonance between where the reward is for our researchers, and particularly those coming up, and where the action actually is, for which there is no remuneration and often no reward.
Is there anybody in the audience who feels that they have, apart from John, have good access to policy makers and decision makers who are willing to listen? Right.
Sometimes.
Some. Yeah, some. Okay. Well, that's good. That's a start.
But that's time. That didn't happen. None of these people, they woke up tomorrow.
No, they've been doing it for a long time.
And it's relationships, and it's iterative, because it turns out policymakers churn. They can probably hear.
Okay, so any concluding remarks, or do you want to translate that, if we have very few show of hands, of how we begin that bridge?
Learn from those who put their hands up.
Agreed.
Okay, so I'll thank all the panel members. Thank you for the audience as well, and we'll transition to the INRICH discussion.